Second white coat. Subscribe and like. Let's learn medicine together.
All right, let's jump right in. Today, we're basically going to be detectives solving this really fascinating medical puzzle. And it all goes down in one of the most complicated, intricate parts of the human body, the brainstem. So the whole mystery really boils down to this one kind of bizarre question. I mean, how can one side of your face and the opposite side of your body lose feeling at the same time? It just sounds wrong, right? Like, how can the wiring in your body get crossed up in that specific way? Well, that's the paradox we're going to unravel today. So here's our patient. We've got a 64-year-old man, and out of nowhere, he gets hit with vertigo and dizziness. But that's just the start. Check out this list of symptoms. It's all over the place. His left eyelid is drooping, and his left pupil is super tiny. He can't feel pain or temperature on his left face, but he's lost the same feeling on the right side of his body. And the real kicker? His muscle strength is totally fine. It's like a classic locked room mystery, but the crime scene is the nervous system. Okay, so where do we even begin with a case like this? Well, like any good detective, you start with the most obvious clues, and in this case, the patient's eyes are practically screaming for our attention. So let's zoom in on that piece of the puzzle first. All right, first clue, ptosis. It's just a fancy medical term for a drooping upper eyelid. And for our guy, this is happening on his left side. And the second clue from the eye is miosis. This means his left pupil is really, really small, constricted. And it's important to remember that it's small, not big and dilated. That's a super common mix-up, but a key detail here. Okay, now here's where things start to click. When you see that drooping eyelid, the ptosis, and that tiny pupil, the miosis, together, well, they aren't just two random things. That combination is a classic sign of a specific condition called Horner syndrome. And bam, that's our first big break in the case. All right, so we've got a name for it, Horner syndrome. But, what does that actually mean? What's going on under the hood to cause this? So Horner syndrome at its heart is all about the nerves. Specifically, something's gone wrong with the sympathetic nerve signals getting to the eye. You can think of the sympathetic system as your fight or flight mode, right? It's the system that's supposed to dial things up, widen your pupils to let more light in, lift your eyelids to see better. So if that signal gets cut, well, the exact opposite happens. The pupil shrinks down and the eyelid droops. So now we know what's broken, that sympathetic nerve pathway, but we still don't know where it's broken. And to figure that out, we have to play detective again and trace the entire route these nerves take, all the way from the brain to the eye. And wow, take a look at this. This shows you just how crazy that path is. It is not a straight shot. I mean, the signal starts way up in the brain, travels down the brainstem and spinal cord, dips into the chest, and then literally does a U-turn and climbs all the way back up the neck to finally reach the eye. A problem could pop up anywhere along this ridiculously long road. We can actually break this whole journey down into a simple three-step relay race, or a three-neuron chain. Neuron number 1 starts in the brain and heads south. Neuron number 2 takes over, leaves the spinal cord, and heads north up the neck. Then the third and final neuron kind of hitches a ride on an artery to make the final delivery to the eye. Simple as that. So this means the problem could be anywhere. In the brain, the brainstem, the spinal cord, even the chest or the neck. The Horner syndrome just tells us there's a break in the chain, but it doesn't tell us which link is broken. To find the exact spot, we have to go back to our other clues. Okay, this is it. This is the moment it all comes together. We're going to take that weird mix of symptoms, the dizziness, that bizarre crossed numbness, and use them to zero in on the exact location of the problem. Just look at this. It's perfect. Every single one of our patient's symptoms can be explained by damage to one tiny little spot on the side of the brainstem, the lateral medulla. Those sympathetic fibers, they run right through there, which gives us the Horner syndrome. The vertigo, that's from hitting the nearby vestibular nuclei. The same side face numbness, that's the spinal trigeminal nucleus. And that opposite side body numbness, that's the spinal thalamic tract, which is already crossed to the other side at this point. It all fits. It's all right there in one spot. And that is the aha moment. The dizziness, the weird cross numbness, the droopy eyelid, they weren't random at all. They were like a perfect little treasure map pointing directly to one place, a lesion in the lateral medulla. And this whole cluster of symptoms has a name, Lateral Medullary Syndrome, or sometimes it's called Wallenberg Syndrome. But hey, what about that other weird clue?
The fact that his muscle strength was totally normal? Well, that's because the main highway for muscle control runs through a different part of the medulla, the middle part. Our problem is on the side, the lateral part. So that motor pathway is completely untouched. The fact that he's not weak is actually a huge piece of evidence that confirms we're in the right place.
Now, a good detective always has to rule out the other suspects, right? So let's take a quick second to see why other things just don't fit the facts here. So you might be thinking, what about a problem with a different nerve, like cranial nerve 3? Well, that's a good thought, but nope. A CN3 lesion can also cause a droopy eyelid, sure, but it causes a big, dilated pupil, the exact opposite of what we're seeing. Our patient's pupil is tiny, which tells us for sure it's a sympathetic nerve problem, not a parasympathetic one. Okay, what if it's a stroke in another part of the brainstem, maybe the pons? Well, once again, the symptoms just don't match up. A stroke in the pons usually causes some pretty severe paralysis and facial weakness, and our patient has none of that. That unique crossed sensory loss is really the signature, the calling card of the lateral medulla. So we've pieced it all together. What's the big takeaway? What's the diagnostic pattern that you should really lock into your brain from all this? Here it is, plain and simple. This is the classic combo to look for. You've got the Horner syndrome, that's the droopy eyelid and tiny pupil. You add in vertigo, and then you top it off with that super weird crossed sensory loss. Same side of the face, opposite side of the body. When you see all those things together, it is not a coincidence. They're a specific fingerprint, and they point to one thing and one thing only: lateral medullary syndrome. And this quote really sums it all up perfectly. This is the bottom line. Crossed sensory findings plus Horner syndrome always makes you think of the lateral medulla. If you see those two things together, your brain should just light up and go straight to that one spot. It's just such a brilliant example of how a bunch of what seems like random, disconnected symptoms can actually come together to tell a very logical, very precise story about what's happening deep inside the brain. And it really makes you wonder, right? What other hidden patterns are out there just waiting for us to figure them out?